Welcome. Today's FERNE educational opportunity discusses the dizzy emergency department patient and the GRACE-3 guidelines which come to the rescue of the emergency clinician. My name is Edward Sloan. I'm an emergency physician from Chicago. I'm Professor Emeritus in the Department of Emergency Medicine at the University of Illinois at Chicago. I'm Medical Director for the Physician Assistant Studies Program at Dominican University, and I'm Medical Director for New Rose Healthcare Management, which helps the staff an emergency department in a safety net hospital on the south side of Chicago. Thank you to the EIM group, the group that initially supported my presentation of this information in December of 2022. I have no financial conflicts. I'm the FERNE President and Board Chair. FERNE has educated emergency clinicians for 2 decades in how to optimize the care of patients with neurological emergencies and injuries. Our educational opportunities. What will be learned from this review of the care of emergency department patients with dizziness and vertigo? Our educational objectives include learning the definitions and pathophysiology of patients with dizziness and vertigo, understanding what diagnoses are likely to be made based on the ATTEST system for differentiating different types of vertigo, knowing how to diagnose central causes for dizziness and vertigo in patients, and how to specify the exact history and physical exam necessary to optimize the diagnosis of patients with dizziness and vertigo, including the HINTS Plus exam and the standing algorithm. And lastly, we will review the SAEM GRACE-3 recommendations that optimize the assessment of emergency department patients with dizziness and vertigo. As background, let's consider dizziness as a complaint for emergency department patients. What questions does the emergency clinician need to consider when evaluating an emergency department patient with dizziness and vertigo? The questions that need to be considered: is it dizziness, vertigo, or some other symptom or diagnosis? What is a differential diagnosis? What physical exam is required in these patients? What diagnostic testing must be done in order to optimize diagnosis? Is neuroimaging required? How should the patient be treated? What is the optimal disposition? And most important, in patients with dizziness and vertigo, the question must be asked, is this a posterior stroke or TIA? How might emergency department patients present with dizziness and vertigo in the clinical setting? Here's an example of a patient with dizziness, a 70-year-old female with lightheadedness for 5 days, worse with getting up out of bed, but intermittently dizzy. The patient has hypertension and cholesterol meds. Her vital signs are okay. There's a normal neuro exam and no nystagmus. Should a CT be ordered in this patient? Another presentation, a syncopal 58-year-old male. He's a diabetic. He's got nausea and vomiting that occurred ×3. Syncope was reported, and he noted bad vertigo. He had to actually lower himself to the ground. It began 3 hours previously and was relatively sudden. He has fast horizontal nystagmus to the right. His HIT test is positive. Skew is negative. He's got mildly unsteady gait, but it seems to be improving. Should the stroke team be called? And lastly, a 44-year-old dizzy male with the sign out from one provider to the other saying, hey, just check the CT. It's a 44-year-old male with a history of hypertension and diabetes. He has 6 hours of continuous dizziness, and he appears to be unsteady with a little ataxic gait. He said he's feeling like I am drunk. He has normal vital signs. He has left nystagmus with gaze, but it appears to be improving. And the one clinician says to the other, if the CT is okay, send him home with some meclizine. Can this patient be safely sent home? How are dizziness and vertigo defined? The consensus definitions are presented, at least in part, by Drs. Edlow and Newman Tokar in a publication discussing the physical exam and the diagnosis of patients with acute dizziness and vertigo. So vertigo is defined as the sensation of self-motion of the head or body when there's actually no real motion occurring. So it's a sensation of distorted motion, and it has to have some component of motion noted in order to distinguish it from dizziness. Vertigo also includes a false sense of rotation, spinning or rocking, or some linear motion such as falling downward or tilting due to gravity. So there might be rotation or linear motion or some type of tilt that the patient notes to be abnormal. Dizziness, on the other hand, is a disturbed or impaired spatial orientation that does not include some false sense of motion. In other words, the patient may feel giddy, lightheaded, not right, the world around them seems fuzzy, but there's no motion associated with this symptom. This is the difference between dizziness and vertigo. So what are the pathologies in peripheral and central vertigo causes and diagnoses? If there's a peripheral etiology causing the sensation of vertigo, somehow the eyes and ears are sending the wrong signals to the brain that cause the person to feel as though there's motion even though none is occurring. So the vertigo pathophysiology includes some abnormality in the vestibular system. The vestibular system normally keeps your eyes oriented appropriately so you don't have any false sense of motion. However, but when one or the other vestibular system in each ear fails due to illness, then there will be a false sense of motion because the eyes and ears will not be communicating effectively. If there's a central etiology to the dizziness and vertigo, then in some way the brain is malfunctioning. When there is a posterior circulation cause for dizziness and vertigo, the consideration is whether or not there's a posterior circulation TIA or stroke. When a stroke occurs in the posterior circulation, it can involve portions of the cerebral cortex, the thalamus, the occipital lobes, the brainstem, including the midbrain, pons, and medulla, and the cerebellum, all which are important for allowing the patient to see appropriately and to be able to have normal gait. So, the posterior circulation provides blood flow to the posterior circle of Willis, allowing these critical brain and brainstem tissues to be adequately perfused and function normally. What are the three vertigo types as shown by the ATTEST algorithm? The ATTEST system allows for a differential diagnosis to be made based on three types of vertigo. Originally published in 2019 December by Dr. Edlow in Emergency Medicine Practice, the ATTEST system is defined and allows us to distinguish what diagnoses may occur based on three types of vertigo. The ATTEST system actually looks at the history and physical of patients with dizziness and vertigo, looking at associated symptoms, the timing and triggers for the vertigo, the examination signs, which importantly include the HINTS plus, and confirmatory testing when indicated. So, what diagnoses are to be considered based on the vertigo timing, triggers, and current symptoms? When making a diagnosis of a patient with dizziness and vertigo, there are several take-home points to be considered. If it's syncope or near syncope, then this is likely the important diagnosis to be made. Or if there's a clinical issue which can be addressed and treated, such as hypoglycemia, hypoxia, anemia, electrolyte abnormality, dehydration, or hypotension, then this also should be considered the principal or primary diagnosis. If, however, the patient is markedly unsteady with standing or gait, cerebellar ischemia should be considered. When considering the vertigo symptoms based on three types of vertigo, we should consider these three types. Is it current and continuous vertigo If so, that is a patient with acute vestibular syndrome. Is it episodic and spontaneous in its occurrence? Then that would be spontaneous episodic vestibular syndrome. If it's triggered and episodic, it would then be triggered episodic vertigo or vestibular syndrome. Please note that nonspecific dizziness is the diagnosis of exclusion, not the first diagnosis. And consider calling the symptom dizziness as the last diagnosis when all other diagnoses have been excluded. How are the ATTEST algorithm vertigo diagnoses summarized? You can see here that there are 3 clinical settings as described, and there appear to be 6 benign and 4 serious causes for these 3 types of vertigo. Acute vestibular syndrome is acute vertigo. The episodic, spontaneous, or triggered are episodic causes of vertigo that have 6 benign and 4 serious causes. What are the benign and serious critical diagnoses in patients with acute vestibular syndrome? If there's no likely medical cause such as hypotension, and there appears to be continuous and present vertigo at the time of evaluation with observed nystagmus, the diagnosis of acute vestibular syndrome can and should be made. What is a benign cause of acute vestibular syndrome? That would be vestibular neuritis or labyrinthitis, which is a peripheral etiology of the acute vestibular syndrome. If, however, it is not this benign cause and it is a central cause, that serious diagnosis would be a posterior circulation stroke of central etiology. What are the benign and critical diagnoses in patients with spontaneous episodic vestibular syndrome? When considering spontaneous episodic vestibular syndrome, if there's no likely medical cause such as hypoglycemia, if it is not triggered by head movement or standing, for example, and there's no continuous and present vertigo, and possibly some observed nystagmus, you can make the diagnosis spontaneous episodic vestibular syndrome. What is a benign cause or causes of spontaneous episodic vestibular syndrome? It would include Meniere's disease and a vestibular migraine, both of which are peripheral etiologies to the SEVS. What would be a serious diagnosis to be considered of central etiology in patients with spontaneous episodic vestibular syndrome? That would include a posterior circulation TIA or a serious cardiac dysrhythmia. What are the benign and critical diagnoses in patients with triggered episodic vestibular syndrome? In patients with no likely medical cause, such as severe anemia, if it appears to be triggered by head movement or standing, without continuous and present vertigo at the time of evaluation, with possible nystagmus, the diagnosis of triggered episodic vestibular syndrome can be made. What is a benign diagnosis associated with triggered episodic vestibular syndrome? That would include benign paroxysmal positional vertigo or BPPV, which is of peripheral etiology. The more serious diagnosis could include a posterior fossa tumor, which is of course of central etiology, or severe orthostatic hypotension, which may be related to a systemic cause. What is the normal timing of symptoms in patients with the 3 vertigo types? This is very interesting. Acute vestibular syndrome usually is sustained for days to weeks. In other words, this patient can have symptoms that persist for some period of time. The spontaneous episodic vestibular syndrome normally has symptoms that occur in the minutes to hours range, not the days to weeks. In those with triggered episodic vestibular syndrome, the symptoms actually may only occur for seconds to minutes, which is much shorter than patients who have spontaneous episodic vestibular syndrome, or acute vestibular syndrome with persistent severe vertigo at the time of evaluation. For more information, email me at fern.org@gmail.com. You can go to our fern.org website or find us at FERNE.org on our social media. We have this content posted on our YouTube channel, and it's available in the small 1-minute lectures on TikTok and Instagram. You can also find us on X, Facebook, and LinkedIn. Thank you for your participation in this educational opportunity today.